put the stream back online. All right, 1 second.
Chris, is it streamed on
It's going to be streaming on YouTube.
okay. And where else?
Just on YouTube.
Okay.
All right.
Mm-hmm.
So Ms. Brown, it's over to you.
Thank you, Mr. Benjamin. Good afternoon, everyone, and welcome to the Consulate General of Jamaica, New York's 2023 Breast Cancer Forum. My name is Donna Brown, and I'm honored to be your moderator today as we come together to discuss important topics related to breast cancer. Today, we have the hardest working Consul General, the esteemed Mrs. Alsion Wilson, Consul General of Jamaica here in New York, and our special guest, Dr. Camelia Lawrence, who is a breast cancer surgeon with the Hartford Healthcare Cancer Institute and comes to us today with over 13 years of experience in breast surgery. Our panelists will share on various aspects of breast cancer, from early detection to treatment options, emotional well-being, and of course, advocacy. During our discussions, we ask that you hold all your questions. We will have a question and answer segment after the presentation. So without any further ado, let me dive into the presentation. And it's over to our Consul General, Mrs. Alsion Wilson.
Thank you so much, Ms. Brown, and good afternoon, everyone that's joining us online. Thank you so kindly for joining us for a second breast cancer awareness forum. As many of you may or may not know, I was diagnosed in 2021 with breast cancer. And of course, Dr. Camelia Lawrence, who's on with us today, was my doctor and still is my doctor. In 2021, actually in 2020, I missed my mammogram. In 2021, I also missed my mammogram as well. And so at some point during 2021, the latter part of 2021, I started feeling some discomfort in my right breast. And so I decided to go in to get a mammogram just to see, you know, what was happening. And to my dismay, I was diagnosed with stage 0 breast cancer. And Ms. Brown just briefly spoke about support from the time that you're diagnosed through the process, how important having family support and friends as well is. You'll hear from Dr. Lawrence as it relates to the support that one needs if they're diagnosed. Of course, Dr. Lawrence, thank God I was able to find Dr. Lawrence, who specializes in breast cancer and is also a Jamaican. She walked me through my entire process. She also performed my surgery and then, of course, ensured that I got better. And now I am happy to say that I am cancer-free. So thank you so much for joining us. And Dr. Lawrence, I will turn it over to you. You can introduce yourself and then we can get going with the program.
Excellent. So as our Consulate General mentioned, my name is Dr. Camelia Lawrence. I am a surgeon by profession, and my practice is dedicated to the management of both men and women who are impacted by breast disease. So I focus both on malignant diseases of the breast, such as cancer, but also benign diseases of the the breast. It has been a privilege and an honor to care for the consulate. I will tell you, since she's been diagnosed and completed her treatment successfully, she has been one of the biggest advocates around this disease process. And I cannot tell you how important that is, because early detection and creating awareness around this disease is so important until we've successfully identified a cure for the disease.
Donna?
Thank you so much, Dr. Lawrence, and thank you so much, Consul General Wilson, for sharing your story. And I'm sure that as we go through this program, you will share a bit more with us on how you overcame and also how you coped after being diagnosed with this terrible disease. So Dr. Lawrence, I'm going to ask you now just to go into your presentation. And I know that you're here with a wealth of knowledge today, and I too am ready to learn.
Okay. One second, I have a little bit of technical difficulties here. And share my screen. There we go, share. Okay, alrighty, thank you so much. So I figure I'd start with the basic and then we can dive into questions as they emerge throughout the conversation. So the title of my talk is just Breast Cancer 101. This is just a standard disclaimer, thanking you for joining us today, but also to inform you that the information today is really intended to be educational in nature. It's not intended for your general, it's intended for your general knowledge, but if you are having any issue or need specific treatment, you must seek medical attention close to home. So,
Hi, Dr. Lawrence, just sorry to
Yeah.
interrupt you. Can you put it in slideshow?
Oh, thank you.
Yeah.
Should be at the end here. Slideshow. No. We had it just now. Here we go. I got it. Thank you. All right. Can you still hear me?
Yes.
Okay, so breast cancer, it's the most commonly diagnosed cancer among women worldwide. In the United States, we say it's 1 in 8. So imagine that you're out for coffee with a group of your girlfriends. There's 8 of you having lunch or supper. 1 of you will be diagnosed with breast cancer during your lifetime. I often say it's very hard not to know somebody who has been impacted by this disease. In the US alone, every 2 minutes, if you think about it, every 2 minutes, a woman is diagnosed with breast cancer. So it's a very common disease process. There's a lot of work behind the scene to identify novel treatments, but most importantly, to identify a cure. But until we identify a cure for the disease, early detection remains the most important tool that we have available. Within the state of Connecticut alone, which is where I currently reside, nearly 12% of the Connecticut adult population will be diagnosed with some kind of cancer during their lifetime. In our state, breast cancer is actually the most commonly diagnosed cancer, but right after that, skin cancer is the most commonly diagnosed, but right after is breast cancer, accounting for about 17% of all newly diagnosed cancer. Now, when we think of breast cancer, I think the image of a woman always comes to mind. It is a disease primarily of women, but men can also be impacted by breast cancer. In the US, every year we see about an average 1 to 2%, which equates to about 3,000 male breast cancer diagnoses per year. Male breast cancer is usually associated with a genetic mutation known as the BRCA2 mutation. And while we don't have screening for men per se, we often encourage men that if you notice any changes within the breast, it could be a lump, it could be a nipple discharge, it could be an enlarged lymph node within the armpit, that it's prudent for you to seek medical attention right away. So what is the most common or the #1 risk factor for breast cancer? Is it family history? Is it female gender and age? Is it having previous chest wall radiation? Or is it by virtue of having dense breasts? And the answer is actually B, which is gender and age. By virtue of being a woman, and a woman, an Asian woman, you do have an increased risk for breast cancer. But not to be overlooked is family history. Family history is king. We know today that the majority of breast cancer that we see, we don't know what caused it, but about 5 to 10% can be due to genetic mutations. And these mutations can be passed through generations. So if you do have a strong family history of breast or ovarian cancer, it is wise for you to have a conversation with your medical doctor. There are genetic testing available to see if you meet the criteria for testing. For example, the most common mutation that we know is the BRCA1 and 2 mutation. It became popular in the media a few years back when Angelina Jolie went public with her story. And what we do know about the BRCA mutation is that it substantially increases a woman's risk for breast and ovarian cancer. And in fact, if you have one of those mutations, the recommendation is that you're not starting your screening mammogram at age 40. Those patients are starting screening mammography at age 25, and they're followed a lot closer. In fact, the recommendation is that once you're done with childbearing, is that you have your ovaries removed. And we also discuss risk-reducing mastectomy with those patients because the lifetime risk for breast cancer is significantly elevated. Now, breast cancer is a disease of, my mom would say, mature women. This is data from the Connecticut Department of Public Health. And you can see the majority of cancers are developing in women between the ages of 60 to 69. So the average age for breast cancer is about 61 nationwide. Our current screening guidelines that we've traditionally adhered to recommends that for the average risk woman is that you start your screening mammography at age 40. Now, if I think that every woman by age 30, especially if there's a family history, should have a risk assessment because your risk may be more elevated and you do need to begin your screening mammography at an earlier age. You may need to utilize MRI as an adjunct to mammography because of your elevated risk. So currently, we recommend at age 40 is for the average risk woman, a clinical breast exam every year and a mammography exam every year. The question I often get at this juncture is about self-breast exam. There is no evidence-based data that shows that self-breast exam improves the overall survival for women. But what I can tell you is that a woman who examines her breast is more likely to know the landscape of her breast. And should there be any changes or abnormalities within the breast, is more likely to seek medical attention right away, which is what we want. We want for you to see the doctor if you notice a lump, there's a skin change, there's nipple discharge, there's retraction, something new is happening within the breast for you to seek medical attention right away. The data that we have shows that screening mammography, that it does decrease mortality. And the goal is that you're finding the cancer when it's most treatable. So mammogram is a standard of care in patients who have dense breasts, and ultrasound may be used as an adjunct. A breast MRI, the American Cancer Society recommends that you use an MRI in addition as an adjunct to mammography, not as a replacement. But for women who have a lifetime risk of greater than 20%, you should consider a breast MRI as well. So a common question regarding your breast is the density of your breast. And when you think anatomically about the breast in simple terms is made up of fat cells. It's also made up of fibrous tissues. There's also dense fibrous tissue within the breast. So this is the level of density within the breast. On the image here, it's 1 to 4. And what you'll notice is that a woman that has a level 1 or a what we call a fatty replaced breast is that everything shows up as black here. Breast cancer typically shows up on mammography as white. So if you were to develop a breast cancer, you would easily be able to see it in this black background. In contrast to a woman who has extremely dense breasts, you can see a lot of white here. If this woman were to develop a breast cancer, it would be very hard to identify because it sort of blends in with this white tissue here. So it makes it harder. So the sensitivity of the mammogram is substantially decreased in women with dense breast tissue. We also know that there's some study and data that shows that women with dense breast has a slightly increased risk of breast cancer. This slide just shows you the image. So this is two different breasts, two women. One has breast cancer here. It's a fatty breast tissue. And you can see the cancer shows up nicely white in this primarily or predominantly Black background. In contrast is this woman who has dense breast tissue. If you notice, the cancer sort of blends in here and makes it very hard for the radiologist to clearly identify that there's a cancer here. So in patients who have dense breast tissue, your clinician may recommend that you add an ultrasound to your mammogram, not as a replacement, but as an adjunct. And the reason being is that the ultrasound is an alternative way for you to sort of scroll through the breast tissue. So if there's an abnormality there, you can pick it up, identify it, and hopefully it's identified very early. So what we know is that early detection of cancer saves lives. It improves health outcome. There are different stages of breast cancer. It's stage 1 through to 4. Stage 0 through to 4. Stage 0 breast cancer is what's also called ductal carcinoma in situ. It's disease that's confined to the breast. Stage 1 is also early stage breast cancer confined to the breast. Stage 2 is breast cancer that's within the breast but may have made its way to the lymph node. Similar with stage 3, we call it local regional disease. Stage 4 breast cancer is cancer that has started in the breast, it has left the breast, it's made its way to the lymph node, and now it has made its way to other organs such as the lung. Breast cancer tends to go to the lung. It may go to the bone. It can sometimes go to the liver as well as the brain. So that's considered stage 4. And stage 4 breast cancer is usually non-operative because the disease is outside of the breast and the lymph nodes, and is typically treated with systemic therapy such as chemotherapy. So early detection is key. Why is that? Take a look at this slide. Is that local disease, similar to disease that the Consulate General mentioned, was that her cancer was caught very early. The survival rate, 98%. But look in contrast to a woman who presents with stage 4 distance disease, that number dropped precipitously to 24%. So there's a huge contrast between a 98% survival rate and a 24% survival rate. And the only difference is really the stage, disease caught very early versus disease that's caught much later. How do we treat breast cancer? There's really 3 major arms for the treatment of breast cancer, and not all patients need all 3 arms of treatment. The 3 arms are surgery, radiation, and chemotherapy. From a surgical standpoint, you're either essentially removing a part of the breast with the cancer along with a rim of normal tissue. You may also look at the lymph node if indicated. Alternatively, you're removing the whole breast because the cancer is so widely involved, usually greater than 5 centimeters, or in some patients may elect to proceed what we call risk-reducing mastectomy if they've had cancer on the opposite side. I'll touch briefly on access and then we can have an in-depth conversation, but access is so key. I am very sensitive to the fact that this presentation is perhaps being streamed in places where access isn't readily available for a mammogram. And in fact, access is determined as one of the critical social determinants of health in terms of cancer outcome. And we can only achieve health equity when every person can live their healthiest life, including communities with higher burden of cancer. So early detection is key. Within the United States, we can say there's no shortage of locations for screening. This is the Kaiser Family Foundation data. The darker blue area shows you the areas where screening mammography is greater than 75 to 81%. So we still have a little bit of work to do in the lighter blue areas where it's about 63 to 64%. But overall, in general, as you can see, that there are several mammography centers widely available where women can present for screening mammography. Disparity remains an issue, even in states where there is access to screening. And the reality is that Black women are twice as likely, almost twice as likely to die of this disease. It's a problem that we've been dealing with for several decades, and hoping at some point that we can make some tangible stride in addressing this issue. It's a complex issue, and there's several factors that can be looked at. One has to do with tumor biology, because not all tumors are exactly the same. We'll talk a little bit about that. Also, underlining patient comorbidities. There's certain risk factors and comorbidities that increase your risk for breast cancer. The one that I think there's so much room for improvement is inadequate receipt of treatment, meaning a woman is diagnosed with breast cancer, but she does not complete the full care continuum. She may do the surgery or she may not do the surgery. She may do chemotherapy, but not follow through for the radiation. So they're not receiving the full recommended treatment in order to effectively take care of the disease. And there are also racial disparities in screening that leads to the difference in stages and the tumor size. As I showed you just recently, is that the stage is very important. The stage at which you're diagnosed significantly impacts your overall survival. And of course, socioeconomic plays a huge role. If you're worried about where your next meal is coming from or shelter, it's unlikely that you're prioritizing a screening mammography as part of your busy schedule, because you're basically in a survival mode. There's some barriers which I think, with education of the public, they can be dispelled. Some has to do with pain and embarrassment, lack of knowledge. There's also distrust, lack of trust within our health system, and there in the United States in particular, there are reasons for this distrust based on our history in terms of the medical community and disparity in treatment. Sometimes it has to do with something simple as transportation. I've had patients who've said, I know I need radiation. It's 6 weeks. It's every day, 5 days a week. I don't have transportation to come back and forth for the radiation, so I just can't do it. Or it may be childcare issue. I don't have anyone to watch my child while I go for treatment. Or it could be related to food insecurity. So there's several, these are social barriers that I think there's plenty of opportunities here for us to work and to try to improve here and improve access. As I mentioned before, not all breast cancers are exactly the same. Whenever there are 4 molecular subtypes, I won't go into detail about this, but I wanted to take a look at the triple negative breast cancer, because this is one of the cancers that's most commonly found among women of color. And what we know about triple negative breast cancer is that it's more aggressive. It tends to have a higher risk of local recurrence as well as systemic recurrence. It usually is more likely to be associated with the BRCA1 mutation. Because it's triple negative, there's no hormonal therapy to treat it. And in the US alone, it accounts for about 10 to 15% of breast cancer death. And we're seeing triple negative breast cancer in younger women of color in particular. There's much to be done around advocacy. Within our state, there's a breast and cervical cancer early detection program that helps to subsidize and offer free services for women who are underinsured or uninsured. Of course, there's certain eligibility criteria as it pertains to income, but it does provide a floor, so to speak, so that women who are potentially uninsured or underinsured can have a screening mammogram done. What can you do, especially to support survivors? We'll talk a little bit more about this, but really it's advocacy, advocating for policy change, speaking up, addressing the inequities that you see within your community, raise awareness about healthy lifestyles. I was recently in a local community giving a talk, and we were talking about the importance of physical fitness, moving. And someone mentioned something as simple as walking, maybe for hard to encourage folks to walk if there's no sidewalk. So, it's not just looking at advocacy in terms of the things that we're recommended, but how feasible are the resources in place, the infrastructure for folks to do it. Why don't I pause there and let's go into a discussion, and we can go from there.
Thank you so much, Dr. Lawrence, for that part of the program. I mean, you've given us so much information. But now, Consul General Wilson, let us go back to you with sharing a little bit more about your story.
Sure. Can you hear me?
Yes, we can hear you.
Okay. So, of course, as I stated a few minutes ago, my journey started in 2021, I believe. It was around my birthday in February when I started feeling a little discomfort in my right breast. I was feeling what I described to Dr. Lawrence as pins and needle, like something just poking at me. Not sure if it was a perfect description, but that's how I felt, like something was sticking me all over. And it would happen quite frequently. You know, in the beginning, I ignored it because I didn't understand what was happening. But because I'd missed my mammogram in 2020, I decided to schedule an appointment just to get a mammogram done, just to see what's happening. And of course, when I went in to get the mammogram, I kind of figured that something was wrong because I realized that I was kept in the waiting area after I did the mammogram much longer than the other ladies that was coming in to have their mammogram. Persons were just in and out while I was just sitting there. And so I started to feel a little worried. And of course, you know, eventually the doctors came in, spoke to me and told me that something was spotted on the mammogram. They wasn't quite sure what it was. And so they needed to have another test done. I did a second round of mammogram, and you know, they kind of said, you know, something is wrong. They will schedule me for a biopsy. I believe it was a week later or so. I insisted on getting the biopsy right away. And I believe it was a week later or so, I went in for the biopsy. And, you know, I recall that it was waiting to get the result was just the most difficult time that I've ever endured. I think I waited for about a week to receive the result from the biopsy. And I was just really agonizing for the entire week. And when I finally received the call from my doctor, not Dr. Lawrence, of course, was my medical doctor, to give me the results, I recalled her saying to me, "Is there anyone with you?" I was in my office, actually sitting in this chair, and she said, "Is there anyone with you?" And as soon as she said that, I realized something was wrong. And I said, "No, but I just need you to tell me what's happening." And then she explained to me that my results came back, and it was positive, she said. And then she said, "But you know, it's a good positive." And I said, "But positive, there's nothing good about positive." She explained that it was stage 0, and it was a good thing that I went in for the mammogram. And then she went into kind of calming me down. I was quite upset. I became very hysterical. And she then calmed me down and explained to me that this is very treatable, and I just needed to act right away. And I immediately decided, I'm not sure why I decided on this, but I immediately decided that the specialist that I wanted to treat me have to be a woman, have to be a Black woman, and if I could find a Jamaican doctor, that would be a plus. And luckily, I didn't know this at the time, that I'd met Dr. Lawrence during COVID. During COVID, we had done the COVID-19 forum, and Dr. Lawrence was one of our speakers. And so I didn't even realize that I had her on. So I went in search of this person, and a friend of mine, Keith Gunn from Hartford Hospital, one day in a Zoom meeting detected that something was wrong with me. It wasn't myself on the call, he said, and called me later on to ask what was wrong. And I told him that I had received this diagnosis, and he said, "Oh, we'll take care of you. We have the perfect doctor. The person you described is Dr. Camelia Lawrence at Hartford Hospital." And so that's how the journey started. I immediately connected with Dr. Lawrence via Keith, and Dr. Lawrence immediately, thanks to her, contacted the hospital where I had my mammogram done and the biopsy, got the result, obtained the result, and brought me in for an exam, and then walked me through the process of how my treatment was going to look like. And so today, and I'll allow her to speak a little bit about, I'll give her full permission to speak a little bit about my treatment and my procedure. But, today, thanks to her and her team, again, I am, cancer-free.
Thank you so much, Consul General, for sharing your story with us. Dr. Lawrence, in over your 13 years, you bring with us expertise and you have seen many stages from different women. So just go on a little bit more about what you have to say as it relates to treatment options, advocacy, and anything else you'd like to share with us today.
Well, I think one of the big take-home message here is that if something doesn't feel right and there is concern, seek medical attention. The other message here is the importance of screening mammography. When I met Consulate General, the exam was completely benign. It just revealed some post-biopsy changes because the majority of breast cancers that are diagnosed, they're diagnosed in mammography, meaning that the woman may not necessarily feel the abnormality. Breast cancer can present in many ways. There are superficial ways in which we can visually see, such as if you can feel a lump or if there's skin changes or nipple discharge, but it can present as simple as microcalcifications. There are little calcium deposits within the breast that even myself as a clinician, I will not be able to appreciate in an exam. But if a woman gets her screening mammogram, they will show up very clearly that, and it will lead to the recommendation for a biopsy. I'll also add that if you've had your mammogram and you're told that there is an abnormality and a biopsy is indicated, please don't defer. Please get the biopsy. The biopsy is needed to clinch a diagnosis. I've had several women who've, had their mammogram. They're told that they either need additional imaging or that a biopsy is indicated, or they need to come back 6 months for repeat imaging, and they just never follow through. When you're talking about breast cancer in particular, time is of the essence. The sooner you know, the more likely it is for you to have your disease taken care of at a treatable phase. The other take-home message is that support is important. I will tell you, when I met the Consulate General, she had a robust support infrastructure, and it included her husband, who I think he was at every single visit. You do need that person, you need that friend. It could be a spouse, it could be a family member, it could be a colleague. It's not a journey that I would suggest that you walk alone, and having a support infrastructure in place makes what's a very heavy and arduous lift a little bit more manageable for women and men as a whole.
May I just add, before you ask Dr. Lawrence the next question, Ms. Brown, support is extremely crucial. And as Dr. Brown just mentioned, my husband, Omar, accompanied me in every single visit. But not just Omar, Mr. Benjamin, our community relations officer, is on with us as well, gave me tremendous support in more ways than you will ever remagine. If it's even just to tell me to take a break, from a meeting, to ask if to remind me that I have an appointment coming up, to ask if I need anything. I remembered one appointment that I went to see Dr. Lawrence, and he called to check to see if I was okay. So support is tremendous, and the small things are very important. The day of my surgery, when I was wheeled in, and I was scared to death, and I was wheeled into the OR room, the last thing I remembered is Dr. Lawrence. She greeted me and she said, "You're going to be well taken care of." And then I remembered her playing Bob Marley, the Bob Marley music, "One Love." And that's how I went to sleep, listening to One Love. It just made me, I felt very comfortable. And that's when I really, truly knew that I was in good hands. So the little things, believe it or not, is quite important.
Mhm. Yeah. I'll just add, Consulate General giving me full latitude to share freely with you. So this is for all the professional women who are on the Zoom or the stream that's online, or even the stay-at-home moms who've committed their time to focusing on their children, is that it's so important for you to prioritize your well-being and your health. I will tell you, when I met the Consulate General, I told her, this is what we need to do. These are the next step. And her first words were, well, the Prime Minister of Jamaica is going to be in New York. We have a major event coming up. I just can't do that. And it was just a testament to her character, her commitment, her professionalism and dedication to her job. And we had to really sit down and, have a courageous conversation that we really need to prioritize your well-being. But I can tell you, I'm guilty of the same as well. We're committed to a profession. We want to make sure everything stays in time. But breast cancer never presents itself at a convenient time. And it's so important for you, if you were diagnosed, to reach out to your support system. They too will jump in and prioritize you as you navigate through this journey, because support does make a difference.
Thank you so much, Dr. Lawrence and Consul General Wilson. Support is very important, because I remember when I did my first mammogram last year. Mm-hmm. Listen, when they told me, you have to do further imaging, I all but passed out. And yes, Mr. Benjamin is always there, our community relations officer. We can call on him, because I texted him and he's like, okay, calm down, step at a time. Just listen to what they have to say and we move on from there. And I called several other persons and they were supportive of me, telling me that, whatever happens, you're not alone. So it is important that we have moral support as well as physical support. Consul General Wilson, any last words before we take the first question that we have online?
Yeah, well, I want to just implore, especially ladies and males as well, to ensure that they keep their appointment, to have their mammogram done. It is very, very important. You heard Dr. Lawrence. She gave you the percentage of persons that, when the breast cancer is detected early, the survival rate is 98% versus 24%. And so it is just very, very important for you to get your mammogram done. Schedule your appointment, get your mammogram done. And, as busy as your schedule may be, you must find a way to get it done. And again, it is important that if you're diagnosed, for you to ensure that you have the proper team around you. The proper team is their doctor that is going to see you through the different stages. And luckily, I found Dr. Lawrence, who is now one of my closest female friends. Of your family and friends, not persons that are going to call someone to say, oh my God, did you know, or did you hear? Someone that is going to call you, every day, every other day, to check in on you, to see that your well-being is, you're being looked after, to offer help and support and guidance. I had one friend who called every day, Miss Karen Mitchell, to ask if I needed her to pick up anything for me to eat, although my husband is an avid cook. So the support that you need to have around you is extremely, extremely important. And lastly, Dr. Lawrence mentioned that if you're diagnosed, that it is important, if your doctor scheduled you, for you to take a biopsy to get it done. That's the one thing that I can say that I did right. When I found out that I was tested positive and the doctor informed me that I needed to get a biopsy, I insisted that I get it done now and not tomorrow, right? And luckily, that helped with Dr. Lawrence, receiving the result, and was able to read the result and then confer with me and then walk me through the stages of my treatment.
Thank you so much, Consul General. Thank you. It is an inspiring story. Dr. Lawrence, we have one question in the chat for you.
All right. Good afternoon, everyone. Chris Benjamin here, Community Relations Officer. So I'll be doing the Q&A. We have a question in the chat, and I know I received one by email yesterday. So I will ask a question from Harriet Zello, one of our big supporters. Harriet, I don't know if you're on, you may want to turn on your camera. But she asks the question, let me pull from the part. She said she was diagnosed with breast cancer and had a lumpectomy at a medical institution. I have a mammogram and ultrasound once a year. I wanted an MRI, but the doctor at that institution said it was not recommended. What is your thoughts on this?
I think by virtue of having a breast cancer, your risk is substantially increased. The MRI is recommended for women with a greater than 20% lifetime risk. So the majority of women who've had breast cancer do meet that criteria of the greater than 20%. So if without knowing her complete history, if she's had a breast cancer diagnosis, she would meet criteria for breast MRI surveillance moving forward. So she can specifically ask her clinician, what is my lifetime risk of breast cancer moving forward? And if it's greater than 20%, the American Cancer Society strongly recommends the breast MRI. And this is not a replacement for her yearly mammogram and ultrasound. In fact, in most institutions, the tests are staggered Q6 months apart. So it's being done annually, but they're staged 6 months apart.
All right. The second question was sent via email by Lerone from Soon Forward. He asked a question. He says that one of our investors in Jamaica has been sounding the alert for radionuclide therapy and peptide receptor therapy as promising cancer treatment approaches. What are your thoughts on these two cell-based cancer treatments?
I don't have much knowledge in that area, so I don't want to comment on something I'm not well versed in. I don't know exactly where the research are. Do they have any clinical trial or evidence-based data currently to support that? I know here in the States, we use standard radiation for breast cancer. There's some discussion, and there's centers that use proton beam radiation, but not the peptides. So I'm not familiar with that.
Okay. All right. Well, those are the two questions. I don't know if anyone else on has a question.
Yeah.
Okay, go ahead, CJ.
Yeah. Dr. Lawrence, can you just speak a little bit to vitamin D deficiency on breast cancer? Because what I have heard in the past is persons, specifically minority persons, are deficient in vitamin D. And so can you just speak a little bit about the correlation between vitamin D and breast cancer?
It's a speculative correlation. We talk about having sufficient vitamin D has to do with a lack of, some of our vitamins that we get is from the sun, lack of exposure to the sunlight. It's important to maintain a normal level of vitamin D. This is something that your primary care doctor can check and assess and let you know whether you need to supplement your level of vitamin D. I don't have any evidence-based data that shows that if you're deficient in vitamin D, that increases your risk for breast cancer. I would think of it as any other vitamins that you want to be adequately supplemented. You don't want to have a deficiency in that particular vitamin.
Okay.
All right, Dr. Lawrence, just a simple question, and this was from a conversation that I was having with someone recently. Can you explain the difference between diagnosis and prognosis?
Okay. So diagnosis is clinching the disease itself, and that's typically acquired through a biopsy, as in the case of breast cancer. So a woman can present with a lump. They can present with redness of the skin. There's several different ways in which breast cancer can present, and we'll clinically say the clinical suspicion is that this woman has breast cancer. But in order to diagnose it, you have to get a tissue sample, have the pathologist look at it and tell you what the diagnosis is. And then the diagnosis would be the breast cancer. The prognosis is how well that person does with the disease after treatment. So we can talk about somebody with stage 0 breast cancer, that they have an excellent prognosis. Their survival approaches 95 to 98%. Whereas somebody that presents at advanced stage, such as stage 4 breast cancer, the prognosis is a little bit more dismal. The 5-year survival is about 24%.
Okay, thank you. And another question which I'm digging here, as it relates to males in particular, I know you mentioned that it's about a 2% chance where males are concerned. Because of the difficulty you mentioned in males being diagnosed, what's the prognosis typically for men who are diagnosed with breast cancer?
So the prognosis actually doesn't differ based on gender. It differs based on stage. So what typically we see is that if you think about the anatomy of the male breast, there's no breast tissue really there unless the man has gynecomastia, which is, breast tissue that's formulated. They'll feel a lump or a mass, and it's usually very palpable on exam, or they'll feel a lump within the armpit, or some may come in and they say, notice my nipple is hard, or it's now inverted. It wasn't before. But if they come in and they're stage 1 or a stage 0, their prognosis is very much the same as a woman who presents with stage 1. What tend to happen is a lot of because breast cancer is not a well-known entity among men, there may be a delay in diagnosis and treatment. So they present much later, or they didn't think it was possible that they could have had breast cancer. So if they present at a later stage 3 or stage 4, then the prognosis is similarly negatively impacted because they're presenting farther along.
All right. And on the point of family history, if one were to, your grandmother had breast cancer, your mother had breast cancer, and aunt has breast cancer, and you are 25 years old, is that something that should be a cause for concern for you at that stage?
Absolutely, unequivocally, it's a yes. So when we talk about hereditary breast cancer, we're talking about exactly what you just described as generational disease. So, my mom had breast cancer, my grandmother had it, maybe an aunt had it, my great-grandmother had it. What that tells you is there's something genetically being passed on and usually what happens is with each generation, sometimes the onset of the disease is a little bit earlier. This is somebody who should be formally genetically counseled and tested. But let's say they undergo the genetic testing and the results come back negative. I often tell patients, we don't take comfort in negative genetic tests if there's such a strong family history, because what that means is that we potentially science may not have yet identified the mutation that is causing cancer in your family. So by virtue of you having such a strong family history of breast cancer means that you are at higher risk. So you're not the average risk where we're going to say you just start at age 40 and just have your screening mammogram. You're at an increased risk, and that risk needs to be calculated, and that needs to be a conversation with your doctor. You're somebody who should potentially be enrolled in a high-risk surveillance program at a breast or oncological center.
Okay. All right. And my final question to you, in reading up on breast cancer, one of the things that I noted, you alluded to one that among Black women, but also because of communities, immigrant communities, there's also a high prevalence, typically because of lack of access to healthcare. What are some of the resources that you would say, for example, among women who are here in immigrant communities who would think that they may not have access? What are some of the things that they can possibly do?
So most states, similar to Connecticut, there's a Department of Public Health, and there are institutions that receive funding at the national and down to the state level that has various screening programs. It's really a matter of being plugged into one of those locations to ensure that you can get the screening mammogram done. So it's really knowing your community. One is education, right? Which is why I do a lot of what I do in terms of grassroots education about the disease, so that it becomes a priority. Like, oh, I haven't had my mammogram done yet. Why haven't I had it done? Is it because of lack of insurance, or because I haven't gotten around to it because I am insured? If it's a lack of insurance, then it's exploring what are the resources available within my community that can help facilitate my ability to get a mammogram. And more often than not, there is a place, a clinic or institution, there are locations that are specifically designed to help cover screening mammography for the uninsured or underinsured.
Okay. Well, I thank you, and I hand back to Ms. Brown.
Thank you so much, Mr. Benjamin. Thank you so much, Dr. Lawrence. And before we hear your last words, Dr. Lawrence, Consul General, your thoughts.
Well, yes, thank you so much, Ms. Brown. I think this has been a fantastic, very, very informative segment. Dr. Lawrence, I have been in constant communication with to have her carve out some time out of a very busy schedule for us to discuss Jamaica and look at how best we can now support Jamaica. Actually, my ideas, I think, are probably a little bit too large at this time. I'm thinking of a research institute in Jamaica, something that would be the largest cancer research institute in the Caribbean. Of course, Dr. Lawrence is on board, and so I would love for this to happen. So we're in constant communication to see how best we can move to educate our ladies in Jamaica on breast cancer. Thank you so much again, Dr. Lawrence. And I don't quite remember when is my next checkup.
Remind you.
As soon as we're finished here, I am going to check to see when, and you best bet that I will be there to get my next mammogram done. So thank you so much. And I would like to thank everyone who joined in today online with us and on YouTube as well. I'm going to ask the CRO, Mr. Christopher Benjamin, to also see if we can save the video, upload it onto Facebook and the various social media platforms, so that persons that weren't able to join us will able to go back and view the video at a later on.
And thank you, Consul General. Dr.
Someone
Lawrence.
just posted, Mr. Raymond, someone just Parkinson.
So that's actually, he's a radiologist. He's of Jamaican heritage as well. Maybe a good person to collaborate with regarding our desire to establish a screening, more widely available screening on the island. So much to come about that. I am delighted to collaborate and to give back to my homeland whenever possible. And thank you to those who've joined us today. I hope the message resonates with you that early detection is key, and the best screening modality that we currently have available is mammography. So please do get your mammogram. And if you have a breast abnormality, please do seek medical attention. Do not be dismissed that it's benign or don't worry about it. It's better to make sure. Thank you.
Ladies and gentlemen, thank you so much. And I do hope you learned something here today, given the wealth of knowledge that was shared by Dr. Lawrence and also our Consul General. Our goal here today was to empower you with knowledge, to provide a network of support, and to inspire you to take an active role in breast cancer awareness and advocacy. So thank you and one love.
Thank you.
Bye-bye.